Okay, thank you very much, Mr. Chairman, dear friends. My talk will be on trigeminal neuralgia, and this is the overlay or the summary of my talk, which will include the review of trigeminal nerve anatomy and functions, going through the definition and classification of trigeminal neuralgia. Then I'll tell you about the imaging technique and particularly how to tailor the imaging study to different segments of the trigeminal nerve, and finally the role of imaging in the diagnosis and management of patients with trigeminal neuralgia. The trigeminal nerve, as you know, is the largest of the cranial nerves. It provides sensory input from the face, motor innervation to the muscles of mastication, and is also responsible for some reflex arches such as the blinking, sound dampening, and jaw jerk reflexes, among others. In its course from the intracranial to the extracranial compartment, we can subdivide the trigeminal nerve into 5 different segments: a brainstem, cisternal, Meckel's cave, and cavernous sinus. These are all intracranial and are best evaluated with MR. And then you have the peripheral divisions, or the extracranial segment of the nerve, that can be evaluated both by MR and CT. So starting at the brainstem segment, here you have the nuclei of the trigeminal nerve, and as you know, this is a mixed nerve, so it has a motor nucleus and sensory nuclei, and the motor nucleus is the most ventral in the pons, and it supplies motor innervation to the muscles of the first branchial arch. These include the muscles of mastication, of course, as well as the mylohyoid, the anterior belly of the digastric, and the 2 tensor muscles, the tensor tympani and the tensor veli palatini. And then you have 3 sensory nuclei, which are located slightly more lateral and posteriorly in the dorsum of the pons. And we begin with the biggest one, which is the chief sensory nucleus, and this nucleus is responsible for the tactile sensation of the face. Then you have the mesencephalic nucleus here in green, which is the cranial extension or the mesencephalic extension of the chief sensory nucleus, and is responsible for the proprioceptive information coming from the muscles of mastication. Finally, you have the spinal trigeminal nucleus and tract, which is the inferior extent of the chief sensory nucleus. It goes all the way down into the dorsum of the spinal cord to the level of C3, and it merges with the dorsal gray matter. It is responsible for the sensation of temperature and pain. From here, from these nuclei, both the motor and the sensory roots move or have an anterior and lateral course to exit the pons at the ventrolateral aspect and enter into the prepontine cistern. The roots are separate, so you have a smaller and more medially located root, which is the motor root, and then you have slightly more posteriorly and laterally the sensory root. They both enter Meckel's cave, but the motor root does not enter the semilunar ganglion, whereas the larger sensory root enters the ganglion itself. Here you can see in a parasagittal cis sequence, you can see the trigeminal nerve coursing through the cistern, and in the coronal plane, if you want to identify the trigeminal nerve, you look at the section where you see that the pons has the largest diameter, and immediately lateral you will see the trigeminal nerves. So the nerves enter the middle cranial fossa through a small opening in the dura, which is called the porus trigeminus, and enters into Meckel's cave. And what is Meckel's cave? Meckel's cave is a dural compartment which is filled with CSF and houses the Gasserian ganglion or the semilunar ganglion. And actually you can often see it on post-contrast weighted images because it enhances and looks like this V-shaped structure in the posterior and medial wall of the cave itself. Whereas the motor root passes beneath the ganglion, the sensory root will enter the ganglion and trifurcate into 5-1, 5-2, and 5-3. 5-1, which is the ophthalmic division, has actually both 5-1 and 5-2 have a cavernous sinus segment, and you can actually see the best sequence to see this is using a T1 with gadolinium, where you can see the nerves as these gray dots inside the enhancing dural sinus. Usually V1 and V2 lie inferior to cranial nerves 3 and 4, and you can see it here. This is cranial nerve 6. V1, or the ophthalmic division, exits the cavernous sinus through the superior orbit, enters into the superior orbital fissure, and it gives off its main branches, which are the frontal, nasociliary, and lacrimal branches. The terminal branch will be the superior orbital nerve, which exits the orbit through the superior orbital foramen and provides sensation to the upper third of the face. V2, or the maxillary division, after a short course inside the cavernous sinus, enters foramen rotundum and goes into the pterygopalatine fossa. Here it gives off its main branches, which are meningeal, zygomatic, and the superior alveolar nerves, as well as the palatine nerves. And its last or terminal branch is the inferior orbital nerve, which turns laterally over the back wall of the maxillary sinus, enters the inferior orbital fissure, and then in the orbit it exits inferiorly through the infraorbital foramen and provides sensation to the middle third of the face. Then finally you have 5-3. 5-3 has both the motor and sensory components. As I told you, the sensory root merges with the motor root. They exit the Meckel's cave through foramen ovale and enter the nasopharyngeal mastigator space. The motor root gives his branches, which is a recurrent branch to the tensor tympani, a mylohyoid branch that goes to the mylohyoid muscle and the anterior belly of the digastric, and finally the big mastigator branch that supplies all the other muscles of mastigation. Then the sensory root gives off its 4 main branches. You have the buccal, the auricular temporal, and then you have the lingual and the inferior alveolar nerve. The inferior alveolar nerve is the terminal branch. It enters the mandible through the mandibular foramen, goes into the inferior dental canal, and exits the mandible through the dental foramen to supply sensation to the inferior third of the face, including the lower teeth and the floor of the mouth and tongue. So, what is trigeminal neuropathy? Trigeminal neuropathy is a general term that is used for trigeminal dysfunction. So, basically, it reflects an end pathway of focal demyelination of the trigeminal nerve or trigeminal ganglion, or microischemia that is secondary to excessive stretching of the nerve. The causes are multifold. You can have intrinsic or extrinsic tumors, you can have compression by vessels, or you can have other pathologies, which the most common are listed here, like multiple sclerosis, infarcts, or neuronitis. Trigeminal neuralgia, on the other hand, is a very specific clinical situation that was defined by the International Association of Pain as a sudden unilateral, severe, brief, stabbing recurrent pain in the distribution of one or more branches of the trigeminal nerve. Furthermore, the International Headache Society added more criteria to the diagnosis of trigeminal neuralgia, which included the paroxysmal and stereotyped nature of the painful attacks. Patients should not have any other neurological deficits, and other causes of pain need to be excluded. Also, electrophysiological studies need to be negative. Using this classification, you can actually subdivide trigeminal neuralgia or trigeminal neuropathy into 2 major groups. One is the classical trigeminal neuralgia, which is the primary or idiopathic, and this includes all cases without an established etiology or that are due to a potential vascular compression. On the other hand, you have the symptomatic trigeminal neuralgia, which is secondary, and include all cases that have a structural abnormality that is causing the trigeminal neuropathy other than neurovascular compression. So, there are some clinical predictors that may tell you if the patient has a classical trigeminal neuralgia or a symptomatic trigeminal neuralgia, and those that are statistically significant include the presence of sensory deficits, bilateral involvement, and electrophysiological testing that is abnormal or positive. If you have that, then most likely you are facing a symptomatic or secondary trigeminal neuralgia. What is the role of imaging? The role of imaging is to identify a structural cause that can be attributed to as the cause of the pain. So it has been proven that conventional brain imaging depicts a structural cause for the pain in 15% of patients, and in most of these patients the cause will be multiple sclerosis or a CP angle tumor. But currently the role of high-resolution CT, MR, and MRA in depicting a neurovascular conflict is actually unknown. So, basically, when you're facing a patient with trigeminal neuropathy, Although the trigeminal nerve has this somatotopic distribution that we have seen in the beginning, trigeminal nerve lesions are very difficult to localize. And why is that? Because the trigeminal nerve has a complex branching pattern and it has a rich anastomotic network. It means in terms of radiology that we have to image the entire course of the nerve from the brainstem nuclei to the peripheral branches in order to make the diagnosis. So what is the best imaging modality? MR for sure. So MR is the only imaging modality that can depict the full extent of the full course of trigeminal nerve. It is mandatory to evaluate brainstem pathology, meningeal and cranial nerves, inflammatory situations, as well as neoplastic conditions, whereas CT may depict the neurovascular foramen and canals and basically is used to provide an anatomical roadmap of the skull base when surgery is being considered. So how do you tailor the MR study to the different segments of the trigeminal nerve? For the brainstem segment, the most useful imaging sequences are fast spin echo T2, flare, and eventually diffusion. And you've seen this image before, so you know that the trigeminal nerve nuclei are located more or less here, in front of the fourth ventricle in the dorsal aspect of the pons. Then you have to consider the cisternal segment, and to look at the cisternal segment, the best imaging sequence is a 3D heavily T2 weighted image, for instance a CIS image, where you can see the nerve as a dark structure crossing the bright CSF within the cistern. Then to look at the cavernous segment, I already told you, so contrast-enhanced T1 weighted images where you can depict the nerves as gray structures in the back, in the high signal intensity or the contrast enhancement of the venous sinus, and then to look at the extracranial segments or the neurovascular foramen, you have to do a high-resolution T1 weighted image where you can see the nerves as gray structures upon the background of the high signal intensity of fat. Of course, if you want to rule out a neurovascular conflict and you need to see the vessels, then you have to do an MR angiography, either using TOF or a contrast-enhanced angiography. Here are listed the diagnostic utility and the limitations of each of these sequences. Turbospin echo T2 flare and T2 star are very useful to look at brainstem pathology or cerebellar pathology, but it will miss the cisternal, small lesions in the cisternal course of the nerve. Heavily T2 weighted images are very, very good to depict neurovascular conflicts, to see the grading, to see the location, but it does not make the differential diagnosis between a neurovascular conflict with an artery or with a vein. TOF MRA is also good for neurovascular conflicts. It may not depict veins or very small AVMs, whereas 3D contrast-enhanced high-resolution T1 weighted images with fat suppression can depict both arteries and veins and is less useful to see the grading of a neurovascular conflict because it doesn't see the cisternal course of the trigeminal nerve so well. And finally, susceptibility weighted imaging may be very useful to detect cryptic malformations, vascular malformations such as venous angiomas, but you have to take into consideration the susceptibility artifacts coming from the skull base. So once you're leading with trigeminal neuralgia, which is that very specific clinical entity that I told you, the pathophysiology, most of the patients will have a compression of the dorsal root of the trigeminal nerve by a blood vessel, and this blood vessel crosses the nerve at the region of the root entry zone or exiting zone, which is a transitional zone from central to peripheral myelination. For the trigeminal nerve, this zone is about 2 to 5 millimeters away from the pons. So what happens is that the repeated pulsatile compression upon the nerve leads to the myelination. The neurons become juxtaposed, and then you have ectopic action potentials that are generated in the sensory root. You have hepatic transmission between touch and pain fibers, and the patients get this episodic shock-like lancinating pain. Because there are certain, or many people have contacts or even neurovascular conflicts but are completely asymptomatic, it is now thought that this is a multifactorial disease that takes into consideration genetic factors, altered pain states, together with atherosclerosis and external compression, for instance by a vessel, or due to reduced cisternal spaces. It is very useful to look at the location of the conflict. Why is that? Because it helps surgeon planning the microvascular decompression when this is being considered, and it also may explain differences in pain distribution. As you know, there's this somatotopic distribution of the roots of the trigeminal nerve, so if you have a conflict here, you will have mainly pain on 5-1 distribution. If you have a conflict that is from below, you have mainly 5-3 related pain, and if you have compression on the medial or lateral aspect of the cisternal segment of the nerve, then you will get mostly a V2 distribution of the pain. It is also useful to look at the site of neurovascular conflict regarding the long axis of the nerve, because it was been proven that if you have a compression at the root entry zone or the transitional zone, you have a typical classical trigeminal neuralgia, whereas if the compression is slightly more peripheral, then you will have atypical pain. It is also very important to look at the grading of the conflict, because it also has been correlated with the success of microvascular decompressive surgery. Grade 1 means a simple contact between a vessel and the nerve, and this is seen in 30% of healthy individuals. Grade 2 implies a displacement and distortion, and this is seen in 2% of asymptomatic individuals, whereas grade 3, that means indentation and thinning of the nerve, is virtually not present in healthy individuals, so you can make a confident diagnosis if you have the appropriate clinical setting. So what are the main culprits of these neurovascular conflicts? Are basically arteries, and the most common is the superior cerebellar, followed by the anterior-inferior cerebellar arteries. Veins are much less common and are much less, they are much more difficult to depict, because these conflicts with veins can be inside the nerve root itself. Veins can bisect the mid portion of the sensory root, or they can run in between the sensory and the motor root, and so they are difficult to depict on MR unless you have a 3 Tesla machine. And often these conflicts with veins, the microvascular decompression is not that successful, so there are many recurrences after the surgery. Here I show an example of a grade 1 vascular conflict with a vascular loop of the ICA. You see the CIS image, the trigeminal nerve, the cisternal segment, and you see this vessel that is crossing the nerve perpendicularly at the root entry or exiting zone. Also, after gadolinium, you can see a small vein which is lying medial to the nerve, also at the root entry zone. So this was a multi-vessel conflict, and it was a grade 1 because you can only see contact, but you don't see indentation or deviation of the nerve. Another example here on a 3D FISP turbo MRA, so you see the arteries are very bright, and you see this vascular loop of the superior cerebellar artery crossing the cisternal segment of the nerve at the root entry zone, but in this case you see indentation and lateral bowing of the course of the nerve. These are the corresponding intraoperative images, where you see that after displacement of the artery, you see the indentation in the superior aspect of the trigeminal nerve. And here is a volumetric reconstruction of a 3D CIS images, where you can see a vascular loop of the ICA crossing the cisternal segment of the trigeminal nerve around 4 millimeters away from the exiting point from the pons in a patient also with trigeminal neuralgia. Another example on CIS, axial and sagittal images, where you again see a vascular loop of the superior cerebellar artery crossing the nerve perpendicularly and displacing and indenting the nerve. You can see it also in sagittal views that the conflict is superior, so probably this patient will have pain related to 5-1 and is displacing the nerve inferiorly. Another example of a multi-vessel conflict, where you see vascular loops of the ICA and of the superior cerebellar artery, which are compressing the nerve. That is seen here, and here on the sagittal views you see the small flow voids compressing the nerve at several points in the region of the root entry zone. And finally, another example of a vertebro-basilar dolichoectasia, where you see the vertebral artery and the basilar artery with this large loop to the left of the prepontine cistern, impinging upon the posterior aspect of the Meckel's cave, which you can see on the normal side, and also displacing the Cisternal segment of the trigeminal nerve superiorly. You have here the corresponding CIS images. You can actually appreciate better the stretching and the displacement of the nerve. There are other vascular causes that you have to consider. For instance, aneurysms, AVMs, venous congestion secondary to cavernous carotid fistulas, and persistent carotid basilar anastomosis, such as a persistent trigeminal artery. Here I show you an example of a giant cavernous carotid artery aneurysm, which was, of course, this patient did not only had trigeminal neuropathy, he had a cavernous sinus syndrome, so the trigeminal symptomatology was not isolated, but in this case it was due to this large aneurysm in the cavernous carotid artery. This is an example, again, of a carotid cavernous fistula, another vascular lesion you may encounter associated with trigeminal neuropathy. You see these vascular flow voids filling in the cavernous sinus, and you can also appreciate this venous congestion of the basilar plexus and of the inferior petrous sinus, and you see this abnormal congestion of the dura that is overlying Meckel's cave that was the cause of the trigeminal neuropathy of this patient. Here I show an example of a persistent trigeminal artery. You see this large vessel that is coming from the basilar artery to the cavernous carotid, and this was actually impinging upon the Meckel's cave, and that was the cause, and was the single symptom that the patient has was trigeminal neuralgia. If you look at the clinical and imaging signs and also to the response to microvascular decompression, you can actually subdivide trigeminal neuralgia into two different types. Type 1 usually includes younger patients. Patients have a shock-like pain. The time of the beginning of the symptoms to presentation is much shorter. The vascular compression is usually due to an artery or a multivessel compression, and they respond very well to microvascular decompression. Whereas on trigeminal neuralgia type 2, the patients tend to be older, the pain is constant, they have longer pain before they come to medical attention, and usually the culprit is a vein, or you don't see any neurovascular conflict, and you may have persistent or recurrent symptoms after microvascular decompression. How can we predict the success of a microvascular decompression? Well, we know that there are around 50% of patients with trigeminal neuralgia do not have a neurovascular compression, so these are not candidates for microvascular decompression. And we also know that there is a good correlation between MR and the surgical findings in patients with trigeminal neuralgia type 1, not as good on trigeminal neuralgia type 2. So, in your report, what do you need to tell the neurosurgeon? You have to tell the type of the vessel that is causing compression. Is it an artery, is it a vein? The grade of the neurovascular conflict, 1, 2, and 3. The site of the neurovascular conflict, so you should measure the site of compression in millimeters from the pons to the vessel. You have to look at the exact location in terms of being superior, inferior, medial, or lateral. The presence of nerve root atrophies, if the nerve is thinned, and also if there is associated arachnoiditis. As you know, trigeminal neuralgia, in most cases, the first treatment or the first line treatment is medical. And when should surgery be considered? When there is failure of medical treatment, or when MR shows structural abnormalities such as neurovascular compression that can be solved surgically. There are many techniques that can be used at second line treatment, such as percutaneous techniques, gamma knife radiation therapy, or microvascular decompression. So finally, just a word on symptomatic trigeminal neuropathy. So if you're looking at trigeminal neuralgia, you can actually perform a study that is directed to the cisternal segment of the nerve. But if you have trigeminal neuropathy, as I said in the beginning, you have to look at the complete course of the nerve. So starting at the brainstem, the most common lesion that gives you isolated trigeminal neuropathy is MS, so multiple sclerosis. It may be the presenting symptom of multiple sclerosis in 4% of patients, and 1% of patients with trigeminal neuralgia or neuropathy have MS. So you see this demyelinating lesion here sitting in the region of the trigeminal nerve nuclei. You can also have infarct, so you see this high signal intensity on T2, on flare, and on B1000 on a diffusion weighted, so this turned out to be acute infarction in the territory of pica, or vascular lesions such as a cavernous angioma, also in the region of the mesencephalic nucleus in this patient. That was the cause for the trigeminal neuropathy. You may also consider neuronitis, so this is usually due to a viral infection. The most common agents are herpes simplex, varicella zoster, or HIV. The problem with this is the differential diagnosis with tumor, perineural spread of a malignancy or metastasis, so serologic testing and follow-up are mandatory. You see this focus of enhancement in the cisternal segment of the trigeminal nerve. In this case, serological testing was positive. We follow up the patient and this disappeared, so this was just trigeminal neuronitis. You have also to consider other infections. This was a diabetic patient with malignant otitis externa that presented with Gradnigo syndrome, and you see this osteomyelitis of the central skull base involving the region of the Meckel's cave, and also this inflammatory tissue that is growing along the trigeminal nerve. That was the cause. Of course, this patient was severely healed, did not have only trigeminal neuropathy. Here I just show you an intrinsic tumor of the trigeminal nerve, a trigeminal schwannoma, that you can see is following the cisternal course of the nerve, as well as is occupying completely the Meckel's cave. Here another patient that had lymphoma. He had been treated with chemotherapy. The disease completely subsided, but he came 2 years afterwards with trigeminal neuropathy. And what he had was this abnormal enhancement along the cisternal course of the nerve as well as in Meckel's cave that after 2 cycles of chemotherapy completely disappeared. So this was a lymphoma. You can have extrinsic tumors compressing the nerve. This is a small meningioma of the petroclivar or posterior clinoid meningioma that is impinging upon the cisternal segment and the Meckel's cave here. That was the cause of the trigeminal neuropathy. You may also have schwannomas of vestibular schwannomas compressing the nerve in the region of the root entry zone, as you can see here, displacing the trigeminal nerve superiorly. And you may have intrarachnoid or intradiploic arachnoid cysts in the region of in the petroclival region. In this lady was the cause of the trigeminal neuropathy. It was compressing the medial aspect of Meckel's cave, as you can see in this cyst image. And another consideration is basilar leptomeningitis, which can be inflammatory, infectious, or tumoral. So you have to consider tuberculosis, sarcoidosis, and of course leptomeningeal carcinomatosis. This patient had a lung tumor. He had various complaints of cranial nerves. You can see the abnormal enhancement along the cisternal course of the nerve, and here also along the internal auditory canal, along the vestibular and cochlear nerves. A more striking case of leptomeningitis from a breast cancer that are completely encasing the cisternal segments of the trigeminal nerve. This was an hematogenous metastasis to Meckel's cave that you can see here from a lung cancer. And of course, you may also have trigeminal neuropathy from involvement of the peripheral segments. Just a couple of examples. You have a squamous cell cancer here of the inferior alveolar ridge that is involving the mental foramen, and you see the perineural spread along 5-3 getting into foramen ovale and into Meckel's cave. And finally, an inferior alveolar nerve schwannoma that is enlarging and remodeling the course of the inferior alveolar nerve. So in conclusion, MR is the modality of choice to determine the etiology of trigeminal neuropathy and neuralgia. You have to use appropriate reporting because this will help the surgeons planning the treatment. High-resolution 3D T2-weighted images and 3D TOF MRA are the sequences of choice to depict arterial neurovascular conflicts. Area contrast-enhanced high-resolution FAT-SET T1-weighted sequences are the sequences of choice to depict neurovascular conflicts with veins. And with this, I thank you very much for your attention.